ATLS updates. It pains me to give this talk. I have a bias. I think ATLS should go somewhere and be buried. At least in Canada, there's some sense. If you have a Royal College specialty training diploma in emergency medicine, you don't have to take ACLS or ATLS or any of the merit badge courses. It's assumed that you're better, your knowledge is better than that. So you never have to get certified in these courses. It is, however, important to realize a couple of things about this. One, American College of Surgeons has made this into a true revenue source. And in fact, the American College of Surgeons is integrated very much into the WHO and is part of GACI, which is Global Association of Critical Injury. And they offer this course around the world for profit. Did you guys know that? So it's very widely spread. Now, the concept that ATLS has of being an organized, structured approach to something is something I agree with. And to show you how much of a difference it can make, because I do, as Rick told you at the start, I'm very much involved in international emergency medicine. In Botswana, the WHO in what are called low and middle income countries, there's not resources to put up stuff like ATLS and expensive courses because the countries can't afford them. So they said, well, we need to structure things in Botswana as they were building their emergency systems. So they came up with a page with 12 questions. No answers. Just 12 questions for you to consider with blunt trauma. So you take them and you just go through the questions as you assess the patient. And you know what those 12 questions with no answers did? It cut mortality by 50%. Which is a remarkable change in care. It gave them a structure around which to assess the patient. And they're not difficult questions. Did you think this patient might have a pneumothorax is one of the questions. And because you have to understand the training is minimal of the care providers that are there. Nurses usually have less than 6 months training. If you go to somewhere like Ethiopia, where nurses are drafted out of high school, they're given 6 months training and they're paid $50 a month. And they have to commit to 5 years' work. They're drafted just like the males are drafted into the army. So how many of those women do you think want to be a nurse? And they have no training. And so even simple things, if structured and everybody does it the same way, it always hear the people in this faculty keep coming back to that. It really does make a difference. Now, so the principle of ATLS is something I agree with. A lot of the content of ACLS I have great difficulty with. Because most of trauma in ATLS is screwy and not based on evidence. It's a structured approach for which it gets great points. Because having a structured approach is better than no structure. So let's go through this. We won't talk about the values of merit badge medicine, because we'll put that aside. Initial assessment and resuscitation. You know, they always used to tell us you have to give 2 liters of fluid, bolus them up. Then we got to 20 cc's per kilo, and then we were talking about this and that. So the thing that they've changed in the ATLS is give 1 liter of crystalloid instead of 2 for unstable patients, or 20 cc's per kilo in children up to 1 liter. So you're supposed to give less fluid as your initial resuscitation. What's that based on? Nothing. Number 1 from 2011 is a retrospective study, so it can't infer causality or infer that there was a relationship that this improved that. It can just show associations. Looked at the elderly getting more than 1.5 liters of crystalloid was associated with higher mortality. Well, I would assume that's because they're getting more fluid because they're more injured, and therefore they have higher mortality. That is a possible association you could infer from a retrospective study. They inferred it's because they got too much fluid. And so they said if you got the elderly, not normal adults, elderly, that if they got more than 1.5 liters, it increased mortality. So therefore the recommendation is, so don't give more than a liter. Okay, you just did a study that said it was 1.5 liters that was the cutoff. So why are you making a recommendation based that says 1 liter? They don't have an answer for that. There's no prospective study. They had a cutoff of 1.5 liters, and they made a recommendation that it should be 1 liter. And although the study was only at the elderly, they made it for every adult. If you can make sense of that, then please come and explain it to me afterwards. We were told to give TXA 1 gram over 10 minutes IV, then the 1 gram over 8 hours. How many of you are doing that where you work, using tranexamic acid for your trauma patients? Okay. And this is based on the CRASH 2 study, which was a huge study and had very valid results for the countries where it was done. But you have to remember that 80 to 85% of patients in the CRASH 2 study came from low and middle income countries that did not have resources, where there were huge delays in times getting to the hospital or getting a surgeon involved, which doesn't apply to North America. So the results of the study didn't apply. Fortunately, there's been another study in the USA that repeated this mechanism and showed that if you have head injury, i.e. you're not having major bleeding, TXA offers no benefit. That TXA can only help about 50% of your patients, the ones who are actually bleeding, intra-abdominal blunt trauma, chest trauma, whatever. And they confirmed that giving TXA into people with major bleeding improved mortality. So it sounds kind of loony, because the recommendation came out that says every polytrauma patient should get a gram of TXA and another gram over 8 hours. But in fact, the repeat study has shown that 50% of trauma patients shouldn't get TXA because it doesn't do anything. It's only ones who are bleeding a lot that should get TXA. Imaging for the neck should be based on either Nexus or the Canadian C-spine rule, but many centers ignore these tools and CT the spine in everybody. We talked about this the other day. Okay, airway and ventilation. So less fluids according to ATLS. TXA if you're bleeding, even though the ATLS course says give TXA to everybody in trauma. Airway and ventilation. This is a remarkable thing. I happen to work, and it's not because I sought this out, it's just the hospital I work at. We are a bariatric center of excellence for the City of Toronto. That means 2 things. One, we see lots of complications of bariatric surgery. Every day we see complications of bariatric surgery. And I have to tell you, the bariatric surgeons are amazing at following their patients and taking care of them. And unfortunately, they get CT'd an awful lot, these patients, because they get hernias, internal hernias, they get microperforations, they get all sorts of complications. So when they come in with abdominal pain, they're taken care of very, very seriously. So we get to know a lot of things that I never thought I'd have to know. The other thing we get when you work in a bariatric center of excellence is you intubate a lot of really big people. So you become really good at intubating really big people. And you learn that it's a very different thing. For example, everybody gets intubated with a head elevation of 30 degrees. And then you realize, well, if it works for the obese patient, it probably works for the slim patient. And so now I intubate all my patients with a head elevation of 30 degrees. There's less aspiration. It's much easier to see the cords. And so I don't intubate anybody flat anymore. Video laryngoscopy is encouraged in this version when doing medication-assisted intubation. Number 4 looked at the CMAC and the glide scope in elective intubation cases and found them compatible. But there has yet to be a study using video laryngoscopy in trauma patients in a randomized controlled study. There is yet to be a study in trauma patients in a randomized controlled study to see what's the impact on C-spine injuries with video laryngoscopy. So these tools have been studied in artificial environments, not real environments. There are people, again, like Ron Walls, who thinks that nobody should be intubating with a regular laryngoscope anymore, that everybody should be intubated with a video laryngoscope. I don't believe that. There aren't the studies to justify that. And every once in a while when you use a video laryngoscope and the person has the, he just doesn't respect you, the patient you're intubating, and he pukes. And so your video laryngoscope can't see a damn thing. So you have to resort to the old way. But you've never been trained. And there are now lots of residents who are coming up who have no training in direct vision laryngoscopy. They've only intubated with video laryngoscopy. And so when they can't see anything because it's all full of puke or blood, they don't know what to do. That's a scary thought. And since it's never been studied in a proper manner in trauma patients with blood and vomit, it's remarkable how this has been forced down our throats by many people. This is what you should be doing based on no evidence. Because it's obvious you should be doing this. So, I would tell you the thing to take away about intubation is the only thing that's important. Make sure you know what you're doing and do it right the first time. Get prepared so that when you try to intubate the patient, you get it the first time. First pass intubation success is the most important variable in outcomes of intubation because it goes exponentially up the adverse effects and the complications if you don't succeed the first time. So you try to intubate, then you have to bag them again, you have to readjust and do things, and you try again. You're already increased aspiration and mortality. So make sure you're set up, make sure you've assessed the anatomy, make sure you have the bedside tools in case you have a difficult intubation, so you have a bougie there. If you're not at all sure what the anatomy is going to be like, just a guy with a big beefy neck, use the bougie when you do the first intubation and pass the ET tube over the bougie. Set yourself up so that you succeed the first time. Shock. The first 4 levels of shock haven't changed, but they've now based their definitions, categories 1, 2, 3, 4, including base deficit. I don't know about you, but when the shit's hitting the fan, the BP is 60 over 40, I'm not waiting for the base deficit to know what level of shock he's got. I sort of find it mind-boggling that you would have to have a lab test result to say, this person's in trouble. But that's what they're asking that you do. Next is the massive hemorrhage protocol for class 4 shock. This is, again, an astonishing review of very little literature to make a recommendation. Study number 5, transfusion of plasma, platelets, and red cells in a 1-to-1 versus a 1-to-1-to-2 ratio. So in other words, 2 packed cells versus 1 packed cell. 1 platelet, 1 plasma, okay? It's basically altering how many red cells you get for every unit of plasma, every pack of plasma and every unit of platelets. So they did this study, number 5, it was a well-done study. And so it turns out that the ratio, whether it's 2 units of packed cells or 1 unit of packed cell, makes no difference. There was no difference in any outcome, and they went deep in outcome measurements, deeper than the power of the study, and found the same 24-hour, 30-day mortality rates, 23 complications reviewed, there was no difference. Giving a 1-to-1-to-1 versus a 1-to-1-to-2 ratio, there was no difference between the two. So the authors there said, and therefore you should give the 1-to-1-to-1 ratio. Okay. Your study just proved it doesn't matter what you do. But the authors were very strong in their claim that you should give the 1-to-1-to-1 ratio, despite the fact their own evidence said that wasn't true. And so ATLS says that's what you should do. Since the average number of red cell packs these people were getting in the study was 12 units, I don't think it was that much of a concern. Now, there was no arm in this study wherein transfusion was based on MG choice, so this did not show superiority over routine care. So the whole question, do they really need that much plasma, is still up in the air. We developed this protocol because we wrote it down on a piece of paper and said this is what you should do, but no one's really determined how many units of plasma you really need. We do know that if you don't give people any plasma, The more blood they get, the greater they are likely to bleed more because they don't have any clotting factors. But no one's determined how much plasma you really need. So this is sort of like we put a bunch of stuff in a bowl, we mix it up, and we made a recommendation. It's sadly not based on hard science. That's unfortunately true in toxicology. It's also unfortunately true in trauma. And whether you want to use the GOBSAT term, I'll leave that up to you. I know. So if you were to ask me, how much plasma should I give a patient with a massive hemorrhage protocol, my answer is, I have no idea. But logic. So, abdominal and pelvic trauma. You'll all be happy to know that palpation of the prostate gland is no longer recommended for suspected urethral injuries. Are you happy? How many of you were doing a digital rectal exam on all your trauma patients? Honestly? Gee, the hands aren't going up. I don't understand. Because there are reasons to do a rectal exam. See if they're bleeding. See if they got toned because they had a spinal injury. I mean, there are reasons to do a digital rectal exam in trauma patients. I can tell you you know the Seinfeld episode of the Magic Loogie? Okay? In medicine, I have learned the magic bullet does exist. You see people who get shot and the bullet ends up in places that you can't possibly understand how it got where it got. Shot in the chest and the bullet's in the brain. How the heck did that happen? Well, it got into a blood vessel and followed the aorta, went up to the brain. I've seen gunshot wounds in the belly and the bullet is beside their anus. I mean, you don't understand where the bullet seems to have a mind of its own once it gets in the human body. Bounces off stuff, changes direction. And so I still think examination of the perineum is still a very important part of trauma. That you're not looking for prostate, I understand. And this comment is a valid comment. A high-riding prostate, well, if you have a short finger, all prostates are high-riding. If the patient's got a very big habitus, so it's hard to get your finger in because they got big butts, so your finger doesn't get in very far, they've got a high-riding prostate. So the recommendation here that don't assess your urethral injuries based on a high-riding prostate, I'm okay with. I think that's a logical recommendation. I can't believe I just said that about ATLS. All right. But can tell you, and I'm sure you've had the same thing, I've seen penetrating trauma where my finger in the rectum, there's all sorts of blood that wasn't suspected. I really have. I really have. All right, head injuries. It's amazing, they say give protein combination complex for warfarin because it reverses it within 30 minutes. Don't give them fresh frozen plasma. And that you give Praxbind for dabigatran. It's absolutely amazing that they make these recommendations when there's never been a study that shows that reversing an anticoagulant has any impact on outcome in head injuries. Because, oh, that's right, the blood's already there. By the time they hit your door with an acute epidural or subdural or intracranial hemorrhage, they've already bled. And there's never been a study that says, well, if I reverse them, they'll do better. The neurosurgeons don't like it. And they want it reversed as much as possible because they don't like all the bleeding when they drain a subdural. That's why they like it. But if any one of us thinks that we're improving outcomes by rapidly reversing these patients, you need to think again because that's never been shown to be true. Imaging in children. I just have a big sigh written here. Obviously, we avoid radiating brains. We've talked about that before. So this is number 10, accuracy of PCAR catch and Chalice head injury decision rules. I'm a Canadian, but I will tell you that the CATCH-2 study was just published in the last year. It was a validation study of the Ottawa group's head rule in kids. It had to have the worst methodology in a decision tool paper I've ever seen. They took the CATCH study, they did the validation study, and it failed miserably. CATCH-2 didn't pick up head injuries. So halfway through the study, and then post hoc, they changed the criteria. And after the study was done, they changed the criteria of vomiting, reanalyzed the data based on a new post hoc criteria and said, look at this, this works. So the catch rule works. It's mind-boggling that they are allowed to publish a paper with that type of change in it by any journal. And then they claimed that it worked when they did a post hoc change of the criteria and a post hoc analysis of the data. That's called a derivation set, but they said it's now been validated. So I will tell you that on its own independent study, and it took 4 or 5 years for catch to be validated because they were having problems with it, that although they compared these 3 studies, these 3 rules, I can tell you catch in its own study, standing on its own, failed to validate itself. Okay? The problem with PCARN, and how many of you are using PCARN? I assume most of you. It hasn't been properly validated either. They take a look, especially their recommendations for children under the age of 2. They didn't collect enough kids under the age of 2. So their confidence intervals said that that PCARN only picked up 91% of head injuries in kids under the age of 2. But they don't say that anywhere in their study. They don't say that they didn't have enough young kids, that their confidence intervals were too wide, and that therefore their lower confidence interval was 91%, and therefore the rule is not adequate. No one says that, even though that's what their data shows. And so everybody uses the PCARN rule. The problem with the PCARN rule, I find, is it CTs way too many kids. It's overly used because it's not specific enough, and so you have to CT a lot more kids than I think is safe. Right. So PCARN works. It does pick up head injuries. There's no doubt about that, but it hasn't been proven to be adequate enough for kids under the age of 2. It CTs way more kids than I find acceptable. I believe the best thing to do with a child is observe them. Watch them. And, you know, one of the bad things in the Canadian healthcare system is you have long wait times in your emergency departments for less injured people, and you actually have long wait times for people who are really sick. We have bad wait times. But you know the really neat thing about wait times? When they see the head injured kid, they've already gone through the window of danger. And so you can tell them to go home. Because what happens, a kid falls, whacks his head, and then they go down the small brain, that brainstem curve of microedema around the vomiting and alertness centers. So the kid gets a little bit drowsy, gets a little bit pale, he pukes a couple of times, then the microedema goes away, and about an hour and a half to 2 hours after the injury, they're fine again. So the wait times in Canada are such that they're past that curve. They're now awake again, so you can say, see, your kid's fine, you can go home. You have to watch them. We know that under the age of 2, until the fontanelle is closed, that epidurals can present with no symptoms up to 2 hours out. So there's a reasonable thing that if you observe a child, and I don't care whether you choose 2 hours or 4 hours, I don't care which one you choose, you identify all the kids who are at risk. I find that far better than CTing people as per the PCARN rule. Okay? You choose what you do, and I understand in the United States the PCARN rule protects a lot of people, and it's very good medical legally. I just don't think it's a reasonable approach because I think it CTs too many kids, and I don't like decreasing cognitive function in kids with CTs. Spinal injuries, we've talked about. Thermal injuries, the Parkland formula is out. 2 millimeters down from 4 of lactated ringer per patient times patient's body weight, so it's 1/2 the amount of fluid. Geriatrics, we talked about the other day, how you have to account for less mechanism injury for higher injuries. Mortality for elderly is related to ISS, but just require less energy to do so. This work, as well as number 12, article number 12, strongly suggests we need to have specific protocols for the elderly in terms of workup, in terms of observation, and what defines high-risk mechanism. I think that's what needs work on. How long do you need to observe them? How long does it take for them to present with their symptoms? What is a high-risk mechanism for an elderly person that wouldn't be considered a high-risk mechanism for someone who's younger? Those are the things we need to work on because they do get high ISS scores. It just requires less energy to get to those high SS scores, and they have delayed presentations that we aren't used to thinking in terms of those presentations.